when you look at CT scans, people get all kinds of CTs, and specifically, I'm talking about CT of the chest, right? And so they'll get CT PE protocol, or they get high resolution chest CT, or they'll get a CT looking at the aorta. How do we define these differences, or what's the evolution of
How
CT?
do we pick which one?
Yeah.
Yeah. It's interesting because we throw around the word high resolution CT a lot. In most academic centers now, HRCT scan is kind of a standard CT scan, but historically, CT scans to try and avoid radiation, people would take thick slices, images of very thick slices of the lung, and then actually skip portions of the lung to take another slice. And so, this would cut down on the amount of radiation exposure. And then HRCT scans basically turn that into thinner slices, but they still may skip portions of the lung, which is okay if you need a few high resolution CT slices to see what the pattern is of the lung disease. But it's not good if you have a nodule or something there, right? You could
Mhm.
easily skip over it. So really now we want to do thin slices, but we want volumetric imaging. So meaning you're imaging the whole lung. You're not missing any parts of the lung. So in fact, there is even overlapping slices. So you don't miss anything, right? This is important when we're talking about pulmonary nodules.
So a pulmonary nodule is really any abnormal soft tissue finding that's well circumscribed that's less than 3 centimeters in size, right? That's what we call a pulmonary nodule in the lung.
Now, when you're looking at pulmonary embolism and things like that, we may throw in some contrast, time it right so we can see what the arteries look like. Is there a clot or something in there to help define that? But when we're really talking about HRCT versus standard CT, the line's pretty blurry now, really.
For those of you watching, when you think about the lung, the basic unit of function of the lung is called the secondary pulmonary lobule. It's like this pentagon shaped structure. There's a pulmonary artery in the center. There's a bronchial in the center. The bronchial is carrying air to the lung. The pulmonary artery is carrying blood to that capillary membrane. So when you take that big breath of air in, where that balloon fills up, you're going to have some gas exchange taking place. Carbon dioxide will come off. Oxygen is going to go into the bloodstream and on the blood cell. And when you're looking at a CAT scan, essentially what you're looking at is a bunch of secondary pulmonary lobules all stacked on top of one another. And when he's talking about slices, he's talking about slices of the lung from top to bottom or bottom to top, however you want to look at, choo, 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 choo. And then they lay it on a screen and you can scroll through and see the different slices and you're seeing secondary pulmonary lobules all throughout it. And if the secondary pulmonary lobule is accentuated, where if the fence that separates the pulmonary lobules is more white, we call it increased lung attenuation, right? Anything that's more white on CAT scan is increased lung attenuation. If it's more black, it's decreased lung attenuation. And that's essentially how we define
Yeah.
the different images we're looking at or the different structures we're trying to see. So imaging really helps us detect the presence of disease.
Yeah. The presence and even what the pattern is can help determine what the diagnosis is.
Pattern meaning like where it's located or where the accentuation is, or
Exactly. So those areas of high attenuation you were talking about, are at the top part of the lungs,
yeah.
at the bottom part of the lungs, at the inside parts or the outside parts. That's kind of helps determine potentially what's driving that disease process.